Hello everyone and welcome to our today's class. My name is Raphael, an expert on psychopharmacology. In my previous classes, I talked about 4 classes of antidepressants. I talked about SSRIs. I talked about SNRIs. I talked about NDRIs and talked about atypical. Now, these are new. These ones are new antidepressants. In today's class, I want to talk about one of the oldest class of antidepressant called the tricyclics antidepressants. Antidepressants. If you like, you can call them tricyclics or simply TCAs. In this session, I'll frequently be referring to this class of medications as TCAs. You can generally identify a TCA medication using a suffix. Most of these medications have a suffix ending in tri, dilene, or I-pramine. Most of them will have suffix ending with trilene or I-pramine. For example, here you can have amitriptyline or nortriptyline or chlormipramine or imipramine or doxepin. Doxepin is a little bit unique. It doesn't have the same suffix as these other medications. So the suffix here, look, try that. Then we have tritylene. Then we have imine. Then we have I-pramine. Then we have doxepin. So these are generic names. So the brand names for this will be Elavil. This will be Pamela. This will be Anna Pranil. This will be Synquan. This will be Tofranil. So those are generic names and brand names. And as I said, some older or old generation providers will write some of these medications using the brand name. Now, these TCAs, as I said, they are the oldest. These are the oldest antidepressants. And there's evidence that they are more effective than the newer antidepressants, but they are not our first choice of medication. Remember, TCAs have an incredibly complex mechanism of action that gives them their efficacy and the burden of the side effects. So they are very good antidepressant, yes, but the side effects is not something we want our patients to deal with. Okay, so it's for that reason that we don't go for them first. We only go for them when other medications have failed. So we're saying TCAs have a burden of side effects that are not very good. We'll look at some of those side effects. Okay, so let's look at some of these medications and what they are indicated for. Let's look at amitriptyline and nortriptyline. We combine these medications together because amitriptyline, once it gets to the liver, it is changed to nortriptyline. Now, amitriptyline is balanced. It's relatively balanced in terms of its effects on serotonin and norepinephrine. So that's important. We are saying that this is fairly balanced. It has a balanced effect on serotonin and norepinephrine. The effect of amitriptyline, Elavil, is the same on serotonin and is the same on norepinephrine. But that's not the case with nortriptyline. Nortriptyline is selective for norepinephrine. That's also very important. So we're saying that this nortriptyline is more selective for norepinephrine. So that difference gives this medication different profiles. In terms of nortriptyline, Pamelo, has less cholinergic effect, less sedation, less orthostatic hypotension. Now, these two, less orthostatic hypotension, less sedation, are important when you're prescribing these medications to older adults, because older adults are more susceptible to falls. So you don't want your patients to fall if they're elderly. You know, if an older person falls, that's a big deal. So you don't want your patients to fall. So in that case, if you really want to prescribe a TCA to your patient and the patient is an older adult, then Pamelo or nortriptyline will be a good option because it's more selective for norepinephrine and therefore has less cholinergic effect, less sedating, and less orthostatic hypotension. Okay, now apart from depression, what is the other indication for amitriptyline and nortriptyline? So other indication here, we're saying that amitri nor depression, and 2, chronic pain. Chronic pain. And the chronic pain here is diabetic, peripheral neuropathy, chronic low back pain, and pelvic. Not just all pains. So, apart from treating depression, this medication can also be used to treat diabetic peripheral neuropathy, chronic low back pain, and pelvic pain. And as you said, they're very effective, but we are not choosing them as first lines. And then we have clomipramine. Clomipramine. This is important too, very important. This is gold standard for OCD. Gold standard for treatment of OCD. Clomipramine is gold standard for treatment of obsessive compulsive behavior disorder. But we do not use this medication as our first choice for the treatment of OCD. We can use SSRI. And as much as it's not as effective as imipramine, we are going for SSRI first because of the devastating side effects, because of the side effect burden of TCAs. We are not going to use it as our first line medication for OCD. Then we have imipramine, this one for nocturnal enuresis. This is bedwetting. Bedwetting. So, imipramine is indicated for bedwetting. Okay? But before you prescribe imipramine to your patient for bedwetting, you should first try behavioral therapy. Okay? Less invasive first. So, imipramine, nocturnal enuresis, bedwetting. Before you prescribe this, start on behavioral therapy. So, it's not first line. Then doxepin. Doxepin, it has a very strong antihistaminic effects. High yield has a strong antihistaminic effect. This doxepin in low dose is pure antihistamine. Low doses of doxepin is pure antihistamine. How is that clinically important? Well, pure antihistamine. This gives doxepin an option for treatment of insomnia. I'll use this color. Insomnia, and also severe insomnia and severe, can't remember that. Severe allergy. I've become tired. So doxepin is a strong antihistaminic. It has a very strong antihistaminic effects, and at low dose, it's a pure antihistamine, and this gives this medication an option for the treatment of insomnia and severe allergy. But we are not going to use this medication as first choice for treatment of insomnia and severe allergy, because we have other better medications with less side effects like trazodone that we can use for insomnia, and Benadryl for allergy. But we are saying that you can only use this when other medications have failed. Okay. Now, let's now look at why we are saying that these TCAs should not be our first choice for depression. And I'll simplify it using the letters TCA. Take a look. So I'll start with talking about TCA. I'll start with T, and let's call these transmitters, or if you want to call them neurotransmitters. And under this, we will say that TCAs block reuptake. So we are saying they block reuptake. Block reuptake of serotonin and norepinephrine. Now, how is this important? How is the blocking of serotonin and norepinephrine important? Well, this is what gives TCAs antidepressant effects. So gives them antidepressant effects. Number 2, C channels. Now, TCAs block or inhibit. So we're saying that TCAs block or inhibit calcium and sodium channels. They inhibit calcium channels, they inhibit sodium channels. How is that significant? 1, the blocking of the calcium and sodium channels gives this medication their analgesic effects. So give them analgesic effects, or I'll use this as a pen. Gives them analgesic. Give these medications analgesic effects. Remember, I told you that amitriptyline and nortriptyline, the Elavil and the Pamelo, they treat, apart from treating depression, they can treat chronic pain, like pelvic pain, like chronic low back pain, like diabetic peripheral neuropathy. Yes, because of the blocking of calcium and sodium channels. Another very important significance of blocking calcium channel that perhaps, that of course is the reason, not even perhaps, it's the reason why we don't go for these medications as our first choice, is because of toxicity. Very, very important. If you forget about everything in this class, remember that TCAs are very toxic. So, toxic nature, toxicity. So this blocking gives these TCAs their toxicity characteristic. They are very toxic. In fact, TCAs are among the deadliest medications used in psychiatry. The deadliest. TCAs have a therapeutic index of 7. Therapeutic index of 7. What does that mean? It means that if you take TCA 7 times more above the normal dose, you'll die. It will be fatal. It will cause toxicity, and you'll die. How do you tell when your patient has TCA toxicity? TCA toxicity, how do you know? TCA toxicity. On an EKG or ECG, it will show with a widened QRS complex. Don't forget that too. On an EKG or an ECG, if your patient has TCA toxicity, you'll have a wider QRS complex. And how is that significant? It will cause arrhythmias and sudden death. Arrhythmias and sudden death. Widened QRS complex. So monitor your patients daily. Get their EKG, monitor so that you find that they don't have this QRS complex, widened QRS complex. And that's why we are saying that TCAs are toxic. So don't use them unless you need them, unless the benefits outweigh the risk. Otherwise, go for these other options. Only if the benefits outweigh the risks. Now, how do you treat TCA toxicity? Treatment of TCA toxicity. As a provider, if your patient has a wider QRS complex and is on a TCA medication, the first intervention, discontinue that medication immediately and put your patient on sodium hydrogen carbonate. So we're using sodium hydrogen carbonate. Sodium hydrogen carbonate. Sodium hydrogen carbonate. Sodium hydrogen carbonate is also called sodium bicarbonate. So treat TCA toxicity with sodium bicarbonate. High yield. Treat TCA toxicity using sodium bicarbonate after discontinuing the medication. Then you put them immediately on sodium hydrogen carbonate. Okay? Now, the last one. So we have looked at the TCA blocking the reuptake of serotonin and norepinephrine. And then we are saying that it blocks calcium and sodium channels, affecting giving the medication analgesic properties, and also it may affect the brain, and it may make your patient have altered mental status and even coma. And then we are saying that that blockage of calcium and sodium channels also makes this medication to be toxic. And the therapeutic index of this medication is 7. That is very toxic if you take 7 times more than the normal dose. Now, the last one is A. So we are looking at TCA. The last one is A. I'm really tired. A is antagonism. Antagonism. So don't forget this too. Don't forget that TCAs antagonize acetylcholine and histamine. They antagonize acetylcholine and histamine. And when acetylcholine is antagonized, this new thing comes in, causes, don't forget this, anticholinergic effects. Never forget that. It causes anticholinergic effects. I write here, anticholinergic effects. Anticholinergic effects here. The antagonism of acetylcholine by TCAs cause anticholinergic effects. And what are these anticholinergic effects? Cognitive impairment. Dry mouth. Tachycardia. Constipation. Urine retention. And blurry vision. So you will see this also when you are on TCAs, because they antagonize acetylcholine, which results to anticholinergic effects like these ones: cognitive impairment, dry mouth, tachycardia, constipation, urine retention, and blurry vision. Now, the antagonism of histamine. I'll use this space here. The antagonism of histamine. When histamine is antagonized, it causes what we call soporific effects, drowsiness, and sedation, which are associated with TCAs. Ladies and gentlemen, thank you for being part of this class. It's been a long class. I'll see you in my next class, where I'll be talking about the last class of antidepressants called monoamine oxidase inhibitors. Thank you very much. This is Raphael, your resource person for psychopharmacology. See you. Thank you.